Welcome, everyone, and thank you for joining today's office hours. I'm Stuart Newsome, and today's session is titled The Payer Provider Temperature Check, the Class 2, or I would say the Class K2 takeaways. Now, before we jump in, just a quick reminder that we will leave a little time at the end for questions as always. So as we go, feel free to drop any questions or comments into the Q&A. And if something I say makes you think, well, that sounds great, Stuart, but that's not how it works in my organization, then definitely put that in there too, because that's usually where the best part of the conversation starts. But today I want to talk about payer-provider collaboration, like I said in the title. And I know that that phrase can sound a little like something that belongs on a conference banner, or maybe a policy paper, or maybe on a slide with a lot of arrows and circles that somehow all point to something that says better outcomes. But for those of us in revenue cycle, payer-provider collaboration is not abstract. It shows up in very real ways. It shows up when a patient is scheduled for a procedure and the authorization requirements are not clear. It shows up when the payer says no authorization was required, but the claim denies later. It shows up when documentation is technically available, but nobody can find exactly what the payer needs. It even shows up when the EHR, or the payer portal, or the clearinghouse, the fax queue, the document management system, and that spreadsheet that we all love, all seem to be telling slightly different versions of the same story. And it shows up when front-end issue becomes a back-end denial. And it definitely shows up when someone says, we have interoperability, but the staff still has to pick up the phone or check a portal, send a fax, and then take a screenshot just in case they need to prove later they did what they were supposed to do. So today's conversation is not about whether payer-provider collaboration is a good idea. I mean, of course it is. The better question is payer-provider collaboration actually making the work easier? Is it reducing administrative burden? Is it improving prior authorization processes? Is it preventing denials? Is it making data more usable? Is it helping staff trust the workflow? Is it helping patients move through the system with less friction? That should be the real goal. Or are we still taking the same old messy workflows and just giving them shinier technology, so to speak? So that's really the issue at hand. Now, healthcare has spent many years talking about interoperability, automation, artificial intelligence, which is now all the buzz, prior authorization reform, administrative simplification, we all remember that one, and payer-provider alignment. Now, I've been a part of those conversations through those years, and I have to admit there has been progress. There are new tools available. There's new standards. There's always new policies. It's like we can't get enough of new policies and regulations, right? And better conversations are happening than they even did years ago. But at that workflow level, that's where things are still messy. And the revenue cycle leaders live in that messy middle. The messy middle, as I'm going to call it, is where payer rules meet clinical documentation. It's where scheduling actually meets authorization. It's where eligibility meets benefits. It's where document intake meets medical necessity. It's where AI meets human judgment. It's where a technical response has to become an operational decision. And it's where collaboration either becomes real or becomes another nice idea that never quite reaches the people doing the work. And that brings me to the KLAS K2 Summit, which was held recently in Salt Lake City, Utah back in May. Now, KLAS K2 brought together payers, providers, technology organizations, healthcare leaders, just about anyone you could think of in healthcare were pulled together, representatives from all these organizations to really talk about some of the biggest friction points in the healthcare system. A pretty big task, and a pretty broad and vague task, right? Well, the themes included payer-provider collaboration on prior authorization, interoperability, AI adoption, administrative burden, data exchange, workflow redesign, and even change management. Now, this is not a typical conference recap that I'm going to give you today. I'm not going to walk you through sessions by session and then say, first this person spoke, and then this panel happened, and then this slide was interesting. That's not especially useful unless you were there. And even then, it may not be the best use of our time today. So instead, think of this session as a temperature check. What do these conversations suggest about the current state of payer-provider relations? Where does the industry seem to be making progress? And where does it still feel stuck? And most importantly, what should revenue cycle leaders take away from it? Because from my perspective, the biggest takeaway from KLAS K2 was not simply that healthcare needs more technology. The takeaway was that healthcare needs better operational execution. We're not starting from zero. Healthcare has plenty of tools, plenty of data, and more APIs than most people can care to think about. And AI is showing up in just about every conversation everywhere, most times ad nauseum. The problem is not whether the technology exists. The problem is whether it's making the work cleaner, easier, and more reliable. So I want to break this down into 4 main insights. First, prior authorization is still the clearest shared pain point, and that should be a no-brainer. It's like a duh moment, right? Second, interoperability exists, but workflow still breaks. Third, AI should not automate the mess, that messy middle I was talking about. And then fourth, denial prevention is where providers can act now. Now, those 4 ideas really capture the temperature of where payer-provider collaboration seems to be headed. So I just want to start with prior authorization. It pretty much was the main theme. Almost every session was dominated, I would say, by prior authorization. And this will not surprise absolutely no one. I should say this will surprise absolutely no one. Prior authorization remains one of the clearest areas where payers and providers both know there is a problem. Oh, we all know there's a problem, right? But providers feel it because it slows down access, creates administrative burden, frustrates patients, and contributes to denials. But payers feel it too, because prior authorization is still a utilization management tool, but the process around it can create a lot of friction, distrust, and even inefficiency with them. Patients especially feel it because they're often the ones waiting, calling, rescheduling, or wondering why a test or procedure is delayed. Or worse, they just abandon the procedure altogether. And staff feel it because they're the ones trying to make all this work across payer portals, plan requirements, benefit rules, medical policies, documentation requests, and changing workflows. So KLAS K2 discussions reinforce something that we all know, but sometimes forget when talking about technology. 1, prior authorization is not just a technical problem. Yes, technology matters. Electronic prior authorization matters. APIs matter. Automation, yep, it matters. And real-time responses, they matter too. But the hard part is not only submitting an authorization electronically. The hard part is trust. That trust issues show up in very practical ways. A staff member may get an electronic response, but if they have been burned before, and I know many of you have, they're still going to wonder, is this payer rule current? Is it tied with the right plan? Is the documentation enough that I sent? And will this hold up when the claim is submitted? And that's the doozy. Now, that is the difference between getting an answer and trusting the answer. And if staff do not trust the electronic workflow, they'll keep the manual workflow alive for as long as they can, because we're all familiar and go gravitate to what we're familiar with. They will check the portal point anyway. They will call anyway. They will fax anyway. And they will take that screenshot anyway. And then the organization ends up in the worst possible place. Not fully manual and not fully automated, but somewhere in between. And that's the place one of the KLAS K2 discussions referred to as a kind of hybrid nightmare. And I think anyone who has worked in revenue cycle knows exactly what that feels like. It's when the new workflow exists, but the old workflow is still running in parallel because nobody is quite ready to get rid of it. It's still kind of working in the background, still leaning on that. Now, that may be the biggest danger in prior authorization automation. Not that automation will fail completely, but that it will only partially work. And partial automation can sometimes create more confusion than no automation at all. Because now staff have to figure out which payers are connected, which services are covered, which plans are excluded, which cases still need manual follow-up, and which exceptions belong with which team. And that's why prior authorization has to be treated as a workflow redesign problem, not just a transaction problem. And this is where orchestration becomes important, because the goal is not to pretend every authorization becomes touchless. Now that sounds great, but it's not how healthcare works. The real opportunity is to separate the work more intelligently. Clean, predictable cases should move with as little manual effort as possible. Cases with missing information, conflicting payer rules, documentation gaps, maybe some plan level variations, or even medical necessity questions, well, they need to be routed clearly to the right person at the right time. Now, that is the balance. Automate what can be trusted, orchestrate what needs direction, and keep humans focused on the exceptions where judgment actually matters. And if we miss that middle layer, automation can create a new problem. It may move some cases faster, but the messy cases still fall into the same queues, the same workarounds, and the same uncertainty. So the goal is not simply to make the authorization move electronically. The goal is to reduce uncertainty. The goal is to reduce rework. The goal is to prevent downstream denials, obviously. The goal is to give staff confidence that when the system says something, they can act on it and believe it. That's a much higher bar, if you will, than just saying we have electronic prior authorization. So my first takeaway is this. Prior authorization is still the clearest shared pain point, but the future is not just electronic submission. The future is trusted workflow execution. And for revenue cycle leaders, that means looking closely at the places where teams are still using backup workarounds. Where are they checking portals after they already have a response? Where are no auth required cases creating risk later? Where are payer requirements still unclear? Where are exceptions sitting too long? Where are the authorizations being worked outside the primary workflow? And where are staff doing extra steps simply because past experience taught them not to trust the answer? The last one is important, because if your staff are doing extra work just in case, well, that is usually not a training problem. That is usually a trust problem. And trust is not rebuilt by telling people the new workflow works. Trust is rebuilt when the workflow works consistently enough that people no longer feel the need to protect themselves from it. Now, the second insight is about interoperability. And when it's been around for a long time, we've been trying to promote interoperability since, 1996 when it first came out in HIPAA, probably way before then. But here's the big idea. Healthcare does not suffer from a total absence of data exchange. That may have been more true years ago, but today the issue is more complicated. We have EHRs, FHIR, APIs, clearinghouses, payer portals, health information exchanges, national networks, and more data moving around than ever before. But the presence of data does not automatically mean the workflow gets better. And that distinction came through clearly in the KLAS K2 themes. The issue is not only whether data can move from point A to point B, the issue is whether the right data gets to the right person at the right time in the right format with enough context to make the right decision. And that's a lot of rights. And that is what I would call workflow grade interoperability. Technical interoperability means data can move. Workflow grade interoperability means the data can actually be used. And that's a huge difference because revenue cycle teams do not get value from data simply existing somewhere. For revenue cycle teams, value shows up when the data changes the work. It prevents a denial. It avoids a manual lookup. It speeds up scheduling, clarifies whether an authorization is required, or gives someone enough confidence to move the case forward. If the data is technically available, but still hard to find, hard to trust, maybe it's incomplete, or it's late, or disconnected from the workflow, then the burden does not disappear. It just moves. And in many organizations, that's exactly what happens. The burden moves from one system to another. It moves from one team to another, from the payer to the provider, moves from the front end to the back end. It moves from the person who submitted the claim to the person who has to appeal the claim. And that's not transformation, that is burden relocation. And healthcare is very good at burden relocation, let me tell you. We create a new tool, but someone still has to check the old tool. We create a new data feed, but someone still has to validate it manually. We create a new dashboard, but someone still has to figure out what action to take. We create a new electronic process, but someone still prints something because the next step is not ready. And that's the difference between data exchange and workflow improvement. Now, the KLAS K2 discussion also raised the issue of data quality and accountability. Now, this is critical because if payers and providers are exchanging incomplete or inconsistent data, then more data does not necessarily mean better decisions, does it? Sometimes it just means faster confusion. And in RCM, faster confusion can be very expensive. It can lead to missed authorizations, incorrect eligibility assumptions, delayed documentation, avoidable denials, or staff spending more time reconciling information than they would have spent doing the original task manually. So the question for revenue cycle leaders is not, do we have interoperability? The question is, where does the workflow still break even though the data technically exists? And that is the temperature check. Where are staff still hunting for information? Where does the data arrive too late? Where does it lack context? Where does it require manual interpretation? Where does it create another work queue? Where does it help one department but create work for another? And maybe most importantly, where does it fail to create trust? Going back to that trust, because trust is the common thread here too. A prior authorization response has to be trusted. A pair rule, yeah, that has to be trusted. So does the data feed. An AI recommendation has to be trusted. That's pretty obvious. And trust does not come from the technology that's existing. Trust comes from the workflow producing consistent, usable results. So my second takeaway is this. Interoperability is no longer just about moving data. For revenue cycle, the next phase is workflow grade interoperability. And that means the data has to be actionable, timely, usable, and tied to the work people are actually doing. Otherwise, it's just another place for staff to look. And I think we can all agree that healthcare does not need another place to look. We have plenty of places to look. We need fewer places to look and better answers when we get there. Now, the third insight, it's all about AI. And I know AI, again, it's ad nauseum out there. It's everywhere. But I think it's important to kind of talk about here. And this one may be the most important because AI is everywhere. Every vendor has AI. Every product roadmap has AI. Every conversation eventually becomes an AI conversation. And AI absolutely has a role to play in healthcare administration and revenue cycle. But one of the strongest takeaways from KLAS K2 was that AI should not be used as magic dust sprinkled over broken workflows. That is my phrasing, but it is the spirit of what came through at KLAS K2. Because if the process is broken and we simply automate it, we may not solve the problem. We may just make the problem move faster. And in revenue cycle, faster is not always better. A bad denial faster is still a bad denial. A bad authorization decision faster is still a bad authorization decision. A bad document routing decision faster is still a bad routing decision. I think you get the picture. Now, AI should help us ask a better question. Not just can we automate this task, but should this task exist in the first place? Is that where the conversation gets more interesting? Well, maybe so. For example, if staff are navigating 10 payer portals, the answer may not be to add AI on top of 10 payer portals. The better question is how to bring payer requirements into one usable workflow. If the team is writing appeal letters faster, that may help, but it does not answer why the avoidable denial happened in the first place. If AI is summarizing large document packets, well, that can be useful, but it also raises a bigger question about whether document capture, indexing, and routing should be cleaner earlier in the process. And if the organization is using AI to chase missing information, there may be a front-end opportunity to identify what is missing before the patient gets to the point of service. Now, this is the shift. AI is not just a tool for doing the same work faster. It should be a tool for rethinking the work, and that does not mean every workflow disappears. Now, I want to be careful, very, very careful here. There will always be exceptions, and there will always be cases that require human review. There will always be judgment calls, payer variations, documentation nuances, and there will always be cases that do not fit cleanly into the rules. And we all like those rules, right? We need guardrails sometimes. But that is healthcare. The goal should not be to pretend everything becomes touchless. The goal should be to let automation handle what it can handle reliably and then route the exceptions clearly to the people best equipped to manage them. And that is the orchestration layer. It is not just automation, and it is not just staffing. It is the connectivity tissue between the two. It determines what can move on its own and what needs humans, who should receive it, what information they need, and how the organization learns from those exceptions over time. And that's where AI becomes much more practical, not as a replacement for people, but as a way to reduce the noise around them so that their time is spent on the work that actually requires their expertise. And that's where AI becomes very practical. It can surface the right information, identify patterns, it can classify documents, prioritize work, it routes exceptions, it can flag missing documentation, and support decision making. But AI still needs governance. It needs monitoring. It needs clear boundaries. It needs high quality data as well as human oversight. It needs to be applied to the right problem. That last part really matters if you're going to look at this, because the wrong AI implementation can make things worse. That's right, I said that. I'm going to say it one more time. The wrong AI implementation can make things worse. If staff do not trust it, they will work around it. If it adds another queue, it creates burden. Now, if it gives vague answer, it creates uncertainty. If it is trained on poor data, it can scale poor decisions. If it's deployed without change management, adoption will suffer. And if it's used to automate a bad process, then it may preserve the very thing the organization should have eliminated to begin with. So my third takeaway is this: AI should not automate the mess. AI should help us decide what work can be removed, what work can be simplified, and where humans should stay in the loop. And that is a very different mindset than let's let AI do everything. And for revenue cycle leaders, I think that is the healthier way to talk about AI. It's less hype, it's more workflow, it's less magic, there's definitely more accountability, and it's less the AI will solve it, but more what problems are we actually solving and how will we know if it worked? And that's the conversation that we need to be having. Now, the fourth insight is where I think providers have the most immediate opportunity, because payer-provider collaboration is evolving. Interoperability is evolving, prior authorization rules are evolving, as well as AI governance. But providers cannot sit back and wait for the entire ecosystem to become rational. That could take a while. And by a while, I mean probably longer than any of us would like. So the question becomes, what can providers do now? And the answer is denial prevention. Now, I'm a big fan of denial preventions, but I'm not talking about denial management after the fact. Denial prevention before the problem becomes a claim issue or an appeal or a write-off or a delayed procedure or even a patient access problem. This is where the revenue cycle team has real leverage, because many denials do not begin at the point of denial. They begin much earlier. A denial may start with incomplete eligibility, perhaps some unclear benefits, the wrong plan, a misunderstood authorization requirement, missing documentation, perhaps medical necessity gaps, payer rules that were not visible, or an order that arrived incomplete. Now, that may also start with a referral or a document that was faxed, scanned, indexed incorrectly, or routed too late. And sometimes it starts because scheduling, clinical teams, prior authorization, billing, and denials are all looking at slightly different versions of the truth. Now, that's why denial prevention is to be front-end strategy. It's not only a back-end recovery function. KLAS K2 themes reinforce this because so many of the conversations point back to administrative burden, back to data quality, documentation readiness, workflow design, and exception management. And those are provider actionable areas. Now, you may not control every payer rule, and especially not control every plan variation, but you may not control how fast the industry standardizes prior authorization. You also may not control every interoperability challenge, but there are areas providers can influence directly. Visibility into the work, exception routing, document capture and indexing, payer rule intelligence, missing information workflows, validation of no auth required cases, and root cause feedback from denials back to the front end. That is the opportunity. And honestly, this is where payer-provider collaboration becomes very practical, because collaboration does not always start with a giant industry initiative. Sometimes it starts with identifying the 2 or 3 payer workflows that create the most friction and working those down. Sometimes it starts with improving documentation readiness for a high denial service line. Sometimes it starts with cleaning up eligibility and benefit verification. Sometimes it starts with identifying the payers where authorization responses are least trusted. Sometimes it starts with asking, well, why do we keep touching the same case 5 times? And that last question is one that every revenue cycle leader should ask often. Why are we touching this again? Why did this come back? Why did this need a call? Why did this require a manual review? How about why did this become a denial? And why did this get appealed? Why did the patient get delayed? Why was the document not available earlier? And that's how denial prevention becomes operational. It's not just a dashboard. It's not just a report, and it's not just a denial code or the reason for why it was denial. It's the discipline of tracing the problem back to where it actually started and then redesigning the workflow there so it does not keep happening. So my fourth takeaway is this. While payer-provider collaboration continues to evolve, providers can act now by improving front-end data quality, documentation readiness, payer rule visibility, document intake, exception management, and workflow visibility. Now that's not glamorous, I know, and it may not make for the flashiest AI headline, but it's where a lot of the real savings and burden reduction and patient experience improvement can happen. And it's where revenue cycle leaders can lead right now. So let's pull this all together. The payer provider temperature check from KLAS K2 comes down to 4 things. First, prior authorization remains the clearest shared pain point, but the solution is not just electronic submission, it is trusted workflow execution. And second, interoperability exists, but workflow still breaks. Data exchange only matters if the information is usable, timely, trusted, and actionable. And then third, AI should not automate the mess. It should help us simplify, redesign, and eliminate unnecessary work while supporting humans where judgment is needed. And fourth, denial prevention is where providers can act now. The work starts upstream, long before the denial shows up on a report. Taken together, I think these insights point to a bigger shift. Payer-provider collaboration is no longer just a policy issue. It is no longer just an interoperability issue, nor a technology issue. It's an execution issue. Can we make the work better? Can we reduce friction? And can we improve trust? Can we give staff better information at the moment they need it? Can we prevent rework instead of just managing it faster? Can we use AI responsibly? Can we stop designing workflows around the assumption that every process needs 3 backups and a fax machine? Maybe that last one is a little ambitious, but it's worth saying. Because the organizations that make progress will be the ones that focus on the messy middle. That is where the opportunity is. Not in the slogans, not in the broad claims, and not in saying AI powered or interoperable or collaborative. The opportunity is in the actual work. It's in the handoffs, the exceptions, the missing documentation, the payer rule variation, the authorization response that nobody trusts, the denial that could have been prevented, the workflow that everyone knows is broken but nobody has had time to redesign. And that's where the next phase of payer-provider collaboration will either succeed or stall. Well, that's all I have for what I was going to say to you. We'll be checking questions in the Q&A. If you have not submitted a question yet, I encourage you to do so. And again, comments. If you have any comments, we always like to share those. We'll read to those as we can get to them. Now, we are running a little short on time, but I do want to try and get to as many questions as possible. So we do have one here. It says, where should a provider organization start if all this feels too big? And yeah, that's a fair question and totally understandable, because payer-provider collaboration and everything that goes with it can feel enormous. And if you try to solve it all at once, you will probably solve nothing. So my recommendation would be to start with friction. Where is the most repeatable, measurable friction in your workflow? Where's your biggest pain point, so to speak, to borrow that cliche or buzzword? Not the most annoying one that's a problem, and not the loudest complaint from last week, so to speak, but the friction that happens over and over again, and that's key, repeatable. Now, for many organizations, that may be prior authorization for a specific service line. For others, it may be document intake, or maybe eligibility areas, or maybe it's a medical necessity issue for denials. Maybe it's payer-specific authorization issues. Could be referral or order intake, whatever the case may be. It may be a specific denial category that keeps showing up, even though everyone knows it's preventable. That's probably the biggest one. I would start there, probably, if that's your issue. Why are we not fixing this? We just keep doing it over and over and over again. You know the definition of insanity, right? So pick a workflow where the pain is visible and felt the most, and where the volume is meaningful and the root causes can be tracked. And then ask questions like, what data is missing? Where is the handoff breaking? What step is manual in this process? Ask if the exception is unclear. What pair rules is not visible to cause this? Can it be duplicated? Where is it being duplicated? Is the work to work on this being duplicated? That's how you make this manageable. You don't start with fix payer provider collaboration. You start with fix this workflow that is creating rework every single day. And I think I'm going to stretch this for one more question if I can. So here's another one. How should revenue cycle leaders think about AI without getting caught up in the hype? Now, there's all types of answers I've heard on this one. It's a very good question. And as I was reading it, I think it may touch on the answer from the previous question just a little in my answer. But this is the question that everyone's been asking. I have heard not just at KLAS K2, but in many other conferences, as well as client calls that we have here at Invenix. So my answer is start with the workflow, not the tool. If the conversation starts with we need AI, then you need to pause. You need to check yourself, so they say. The better question is, what work are we trying to improve? What are we trying to accomplish? So once you understand the work, then you can decide whether AI is the right tool. Sometimes it will be. Sometimes a rules engine is enough. Sometimes better integration is all you need. Sometimes better training or change management may be the real answer. Sometimes the workflow should simply be eliminated or changed or altered. That's the key. AI should be evaluated by whether it reduces the burden. Is it going to improve the process or accuracy? Is it going to support trust, like I was saying earlier, and create measurable value to your operation? Not by whether it sounds impressive on a board deck, and certainly not by whether everyone else is talking about it. So with that, I don't see any other questions as I'm looking down one more time. I just want to thank everyone for joining me today for office hours. As you notice, I was solo. Typically, we do have guests. We are going to have a great guest. Seeing that this is the week before July the 4th, next week we are going to forego an episode of office hours, so we'll see you back July the 9th. I just want to encourage everyone to sign up for that. It's going to be some exciting stuff that'll be forthcoming in all of our promotions. Again, thank you very much. And be sure to catch our Revenue Cycle Optimized podcast and visit us at Infinix.com for more articles, case studies, and insights on all things revenue cycle. Thanks again, and we'll see you next time.